can everyone see this? This is looking like a normal plasma cell. Okay. Can you see that all of the plasma cell, they are having a perinuclear clearing, which we call it as, what do we call it as? We call it as perinuclear HOF.
Hello.
Or halo. Or halo. Now, can anyone tell me what is the cause of this perinuclear HOF? Because of accumulation of Golgi apparatus around the nucleus. This is the cause of the perinuclear HOF, and this is normally seen in a plasma cell. Now, what we can also appreciate that there are certain multinucleated forms. Yes or no? There are certain multinucleated forms. Everyone will appreciate this. Yes, so this is the bone marrow. And over here, clearly from this picture, we can also say that the percentage of plasma cell is more than 10% over here. Yes or no? So this was the first criteria for the diagnosis. So this was the first criteria for the diagnosis of plasma cell myeloma, as we can appreciate. Yes or no? Now we can see that there are certain multinucleated bizarre forms. Now, can anyone tell me what is this? What is this that we appreciate over here? Pardon, I couldn't hear. What does the plasma cell do normally? What is the function of plasma cell? It is to secrete increased amount of immunoglobulins or antibodies. Now, these are tumor cells that is going to secrete excessive amount of immunoglobulins. Yes or no? So over here, if you can appreciate, this is one cytoplasmic inclusion which is containing excessive amount of immunoglobulin. Especially this is one endoplasmic reticulum containing excessive immunoglobulin secretion. And what is this called as? Yes, can anyone tell me? It is called as Russell bodies, which we have already studied. Where we have studied in general pathology, we have studied about Russell bodies. This is what is the nature of this? This is one kind of a protein. This is one kind of protein, if you will appreciate. Now, sometimes what happens that this entire cell is containing multiple such grape-like vesicles. Okay. For example, how we can see and appreciate over here. And this is called as a MOT, M-O-T-T, MOT cell. Okay, when they contain multiple such Russell bodies or cytoplasmic inclusion bodies, we call it as a MOT. So this is the normal electrophoresis where there is a spread of proteins. Okay, so there's a gamma protein, A protein, M protein, and then you have kappa lambda chains like this. Then if you want to spread out, you have to carry out immunofixation. So normally you can see the gamma, you can see the A, and you can see the M. IgM, Ig, IgG, and the light chains you can see they are equally distributed. Okay, this is the normal spread. But in case of plasma cell myeloma, you can see, compare over here, there is a very dark band. We call it as the M band. Okay, we call it as the M band. If we are carrying out immunofixation and we are going to spread out the components, we are over here, for example, we see there is one class, that is the IgG class of immunoglobulins are characteristically raised. And as I told you, the light chains are also raised. And if you see, out of them, only one type, the kappa variety, is increased. So over here, the kappa variety is showing an increased band. Okay. So this is how we appreciate, and this is how the characteristic electrophoretic pattern can be seen in multiple myeloma. So let us start today's topic of discussion. Today we are going to read about plasma cell neoplasm and the related disorders. Okay. So before I go into multiple myeloma, which is the most important topic of discussion, I just wanted to give you a head start as in what is the spectrum of plasma cell disorders. So the first very important spectrum is MGUS, that is called as monoclonal gammopathy of undetermined significance. It is basically a precursor lesion of multiple myeloma. Then we have the most important multiple myeloma, that is the plasma cell myeloma, wherein we have different variants like smoldering myeloma, non-secretory myeloma, and plasma cell leukemia. Okay. Now just remember, normally multiple myeloma is involving the bone marrow. Okay. And the myeloma cells are present in the bone marrow. What are the myeloma cells? These are nothing but neoplastic plasma cells. They are present classically in the bone marrow. So in case of plasma cell leukemia, the plasma cells, the neoplastic plasma cells, they enter the blood. In that case, we call it as plasma cell leukemia. Then we have what is called as a plasma cytoma. Now, what do you understand by a plasma cytoma? Now, plasma cytoma, basically, it is nothing but it is a neoplasm comprising of neoplastic plasma cells, but instead of being present inside the bone marrow, they are present in the form of a mass. So they can occur in any part of the body, and they are just like a tumor mass. Instead of being, inside the bone marrow, it is there as a mass, okay, not spread out, okay, it is as a mass. So it can be a solitary, it can be a solitary plasmacytoma of the bone. That is, for example, if this is the bone, okay, so on the outer aspect you might have a mass, it's a solitary plasmacytoma of a bone, or outside the bone there might be an extra osseous, extra medullary plasmacytoma. That is, for example, in any soft tissue you will have another mass comprising of neoplastic plasma cell. That is what a plasmacytoma is. Then we are having monoclonal immunoglobulin deposition disease. So sometimes what happens that the plasma, the neoplastic plasma cells, okay, just remember they secrete two things. They might secrete a complete antibody, okay, they might secrete a complete antibody, and this complete antibody is comprising of two things. One is the heavy chain plus there is a light chain, or they might secrete just what is called as a light chain. Now remember, this light chain can either be of kappa or lambda variety, okay. So basically these are the two contents that is released by the plasma cell, okay. So just remember one thing, that there are two components released by the plasma cell. One is the entire antibody comprising of heavy and light chain. This is also called as the M component, okay, M standing for the multiple myeloma protein, or M protein, okay, that is comprising this entire, and there is something called as light chain. So either your kappa or your lambda light chain is produced in excess, not both of them. So for example, in certain multiple myeloma conditions, there's an excessive production of your light chains. That is, these light chains are produced in excess, especially this lambda light chain. And this lambda light chain can deposit, okay, it is one of the important components of amyloidosis. So remember, in in certain disorders, that this lambda light chain might deposit as an amyloid, okay, and in that condition they form what is called as a deposition disease, and they might lead to primary amyloidosis. Okay, similarly this light chain might just deposit, okay, might just deposit in some other part of the body as a non-amyloid. So in that case they can give rise to systemic light chain deposition, or sometimes just heavy chain might deposit, that is called as heavy chain deposition disease. And there are multiple syndromes associated with plasma cell neoplasms, like Poem syndrome and Temple syndrome. So remember, this is the spectrum: MGUS, plasma cell myeloma, plasmacytoma, monoclonal immunoglobulin deposition disease, and the paraneoplastic syndrome associated with plasma cell myeloma. So all these are basically under the spectrum of plasma cell neoplasm. So this is the classification. So let us understand few things about plasma cell neoplasm before we go into multiple myeloma. So just try and understand one important thing, that all this plasma cell neoplasm that we are watching, that we are seeing, they are basically arising from the B cell. So plasma cell neoplasm are basically B cell neoplasm. Okay, and basically these are neoplastic plasma cells. Okay, they are monoclonal in nature, and they are secreting a monoclonal immunoglobulin. Okay, either the whole antibody is secreted or a part of antibody is secreted. I told you, just remember that an antibody is having two parts. One is there is a heavy chain, there is a light chain. So either they might produce this entire fragment, in that case we call it as the M component, or they might just produce the light chain, which can either be of lambda or kappa variety, okay, or they might just produce heavy chain. Okay, so depending on which component is produced, we have that particular symptom. So I hope you understand what I am telling you. And all this M component that I am talking about, they are basically used as a tumor marker. Now, the most common of all this neoplasm, if we are going to see, is multiple myeloma, also called as plasma cell myeloma. Okay. Now, very importantly, as I told you, in all these plasma cell neoplasms, you will identify a monoclonal immunoglobulin, as I told you. And this monoclonal immunoglobulin is referred to as the M component. And this M basically stands to myeloma. Okay, that is why we call it as M component, called as myeloma component. Now, remember one thing, that this is restricted to the plasma and extracellular fluid and excluded from urine. Remember, this M protein that we see, M protein, always remember this M protein is present in plasma. It will be present in any extracellular fluid, but it is never present in urine, because these are very large proteins and they can never come inside. Okay, they can never come inside the urine. So M protein or M component is never seen in urine. Okay, remember. Now, because this is a tumor which is basically involving the plasma cells, which is having this, okay, so what do you expect? What is the normal function of the plasma cell? Yes, can anyone tell me what is the normal function of the plasma cell? They are to they are to secrete immunoglobulins
And
or antibodies.
immunoglobulins.
So that is how this monoclonal immunoglobulin comes into the picture. So they are synthesizing two things. One is the M protein, which is the complete antibody comprising heavy and light chain, and along with that they will secrete some kappa or lambda chain. So they will either secrete kappa or they will either secrete lambda, but they are not going to secrete both. Either of them will be secreted in excessive amount. Okay, as I told you, most patients of plasma cell tumors, the levels of free light chain is elevated and markedly they are skewed towards one chain. Okay, so either kappa or lambda is going to be in excessive amount. Okay, so most commonly it is the kappa variety which becomes most commonly elevated. Okay, now remember, because the free light chains, that is, we are talking about the kappa or lambda free light chains, because these light chains are smaller in size, so they can be secreted in urine. Remember, they can be secreted in urine. Okay, and this is called as Benzone proteinuria. Okay, Benzone proteinuria. And remember, these light chains are very damaging to the kidneys and they are responsible for kidney failure in multiple myeloma patients. Okay, is this very clear? So you should be able to understand what is an M protein. You should be able to understand what are free light chains. Okay, what are the types of free light chains? You should be able to understand about that. Okay, now I'm just going to go, whatever classification I had given you, I'm just going to give that classification once more. So multiple myeloma, also called as a plasma cell myeloma, it is the most important out of the lot, and it is usually presenting as tumor masses scattered throughout the skeletal system. That is, the bone marrow is just involved in plasma cell or multiple myeloma. Now, when I'm talking about solitary plasmacytoma or solitary myeloma, that means just a single mass. It is not a systemic, it is rather a localized condition. So it can either involve the medullary cavity of the, not medullary cavity means on the surface of the bone it might be, or it might involve any soft tissue, but there will just be a single tumor mass comprised of neoplastic plasma cell. Now, what is smoldering myeloma? It is a variant of multiple myeloma, as I told you. So no sign symptoms will be present in smoldering myeloma. Now, what are the sign symptoms? I'm going to tell you later on in the video. Okay, but they have high amount of M component. So M component are present, but they do not show any sign symptoms of the disease. Just there is presence of M component, then you will call it as smoldering myeloma. Now, in Walden's term, macroglobulinemia, it is a syndrome where one of the type of immunoglobulin, especially the IgM variety, is increased. Now, because IgM antibody is very heavy, so they lead to hyperviscosity of the blood. And it is usually seen in older adults, most commonly in association with a lymphoma called as lymphoplasmacytic lymphoma, which we are going to discuss in the later part of the video. Now, as I told you that these patients, they can secrete heavy chain and light chain separately. Okay, so when they are exclusively releasing just the heavy chain, okay, it is a very rare monoclonal gammopathy and can be seen in association with multiple disorders, including lymphoplasmacytic lymphoma. Also, it can be seen in small bowel marginal zone lymphoma. So heavy chain disease can be associated with either of them, wherein just the heavy chain of the antibody is secreted. Okay, and remember, the common chain is the secretion or synthesis and secretion of free heavy chain fragments. Remember, I told you in case of multiple myeloma, either the M component, which is the entire antibody comprising heavy and light chain, and free light chains are just produced, which might be lambda or kappa only. Okay, so normally heavy chains are not found in multiple myeloma. If the tumor is just secreting the heavy chain, okay, in that case we call it as a heavy chain disease, and it is a rare condition. It is a rare condition. It is not a normal condition. Okay, it is a rare condition. Okay, now the fifth variety is your primary or immunocyte associated amyloidosis. As I told you, because the patients of multiple myeloma are also secreting the free light chains. Okay, so I told you we have lambda and kappa. Now, when the lambda light chain is in excess, they can form amyloid protein and can lead to primary amyloidosis. Okay, primary amyloidosis can occur, and it doesn't occur in all types of multiple myeloma, that but some varieties might lead to that. And finally, we have one component that is the precursor of multiple myeloma called as MGUS, that is monoclonal gammopathy of undetermined significance. So in such cases, they do not have any sign symptom. The only thing that they have is very small to moderately large M components can be seen in the blood. That's it. It is common in older agents, and there is a risk of converting into multiple myeloma. It is regarded as basically, or mainly it is regarded as a precursor to multiple myeloma. Okay. Okay, now we are going to start the most important section, that is multiple myeloma. Very, very important. So I have shown you the WHO criteria for the diagnosis of multiple myeloma. So very important thing, that for PCM, that is the plasma cell myeloma, the criteria is that when you do a bone marrow examination or aspiration, inside that the amount of plasma cells should be more than equal to 10%. This is the first criteria. This is either this, or for example, if the patient is suffering from plasmacytoma, okay, for example, there is a mass that was seen in radiology and you have done a biopsy from that particular mass. So in that mass, you can see that there is a plasmacytoma, a group of cells containing just plasma cells. Either of this should come out to be positive and more than equal to one of the following myeloma defining events. So what are the myeloma defining events? They are actually CRAB, that I was telling you, the sign symptoms. So in all multiple myeloma patients, they have these sign symptoms. They will have hypercalcemia, where the amount of calcium level is more than 11 milligram per deciliter. There is a renal insufficiency. Why there is a renal insufficiency? Because of which protein? Because of Benz Jones protein, as I told you. Now over here, the levels of serum creatinine is more than 2 milligrams per deciliter. And lastly, then thirdly, we are having anemia, where the hemoglobin level value is less than 10 grams per deciliter. And bony lesions will be there. So if you carry out an X-ray, CT, PET CT, at least you will have one osteolytic lesion present in skeletal radiography. At least one osteolytic lesion is present in skeletal radiography. Okay, so these are the lesions. So either you should have, this is a must, 10% plasma cells plus at least one of the myeloma defining event, that is the CRAB lesion, should be present. Now WHO in the latest edition have included what is called as the biomarkers of malignancy. If any one of them becomes positive, then the patient is taken to be as positive of multiple myeloma, irrespective of the plasma cell percentage. Now, for example, the bone marrow contains more than 60% plasma cells. In that case, you do not require any of the CRAB lesions. You can straight away give the diagnosis as plasma cell myeloma, because this is one of the biomarkers of malignancy. Or for example, if the ratio, for example, the ratio between lambda to kappa, okay, if we are looking at the ratio between lambda and kappa, for example, if you're looking at the ratio between lambda and kappa, okay, so normally, for example, as I told you, that there will be increased synthesis of one of the lambda or kappa chains. Yes or no? We have discussed this. Yes. So basically, for example, over here the kappa chain is increased. So how much is increased? If the increase is so much that the ratio between this and this and this, if you can see, the ratio between this is approximately 1:100 or more than this. If it is 1:102, so if this becomes more than 100, means the amount of kappa is actually 100 times more as compared to the other one. If we see, in that condition, this is again one of the biomarkers of malignancy. Okay, it is called as one of the biomarkers of malignancy. Is this clear to everyone? Yes. This is the second important this thing. And the third important thing is, if there is more than equal to one focal lesion on MRI. If on MRI you can see any one focal lesion, we call it as a multiple myeloma. So these are the biomarkers of malignancy. Okay. So remember, if they ask you the question, which are the myeloma defining events, you will first say about the end organ damage, that is the CRAB. I have explained you what the CRAB lesions are. I have also explained what are the biomarkers of plasma cell myeloma. These are these three lesions. Okay. So remember this. The for diagnosis, basically 10 plus this CRAB is required. And if, for example, any of these biomarkers are present, then these are actually markers of malignancy. So this is about your plasma cell myeloma. Now, as I told you, in case of smoldering variety of plasma cell myeloma, what did I tell you? That the M component or the M protein will be there in the serum. That is equal to more than 30 gram per liter. Okay, or urinary M protein is more than equal to 500 milligram per 24 hours. Over here, the M protein we means lambda or kappa. Light chain is what we are meaning. And the plasma cell percentage is between 10 to 60%. Why between 10 to 60%? Because if it becomes more than 60%, then it becomes plasma cell myeloma because it is one of the biomarkers of malignancy. Okay, and there should be absence of any of the crab. Crab should not be present. The patient shouldn't be suffering from amyloidosis. Is this point crystal clear to everyone? Yes. Okay, the criteria is clear to everyone. Okay. So multiple myeloma, it is a plasma cell neoplasm commonly associated with lytic bone lesions. Okay. Then because what do you mean by lytic? Lytic means what? That there is an increased activity of the osteoclast. So for example, this region of the bone is completely gone. This region of the bone is gone. So what happened? Whatever calcium was there, from there it came into the serum. That is the cause of hypercalcemia. And whatever the plasma cells are secreting the lambda or kappa chains, okay, that is going in the form of Benz-Jones proteinuria into the kidney, which is causing kidney damage, leading to renal failure. And how do you see renal failure? By elevated serum creatinine levels of more than 2 milligram per deciliter. Okay, and you have certain acquired immune abnormalities because the plasma cell cannot produce correct antibodies, or good antibodies cannot be produced by the plasma cells. Because of this problem is arising. Okay, there will be recurrent infections in the individual. So predominantly the plasma cell myeloma is involving the bone, and this is a disorder of older patients, usually 65 to 70 years of age. Now, coming to the pathogenesis of plasma cell myeloma, very, very important that multiple myeloma is showing certain rearrangements involving the IGH gene, IGH locus on the chromosome number 14. Also, they are involving certain cell cycle regulatory genes like cyclin D1 on chromosome 11 and cyclin D3 on chromosome number 6. Now, very importantly, sometimes they also show mutations involving TP53, and those cases showing TP53 mutations have a poor prognosis. Now, there is a variant of plasma cell neoplasm called as plasma cell leukemia, wherein you are going to see the plasma cells or the plasma blast inside the blood. Now, that is a very aggressive variant, and such variants are associated with mutations in MYC. Now, in any kind of WBC disorder, even including Hodgkin's lymphoma and other kind, what you see that there is a pathway, that is a growth pathway called as NF-kappa beta pathway. So this pathway is excessively, excessive signaling goes through this pathway. And normally this pathway is basically promoting growth and survival. So even in multiple myeloma, there is an excessive stimulation of NF-kappa beta pathway leading to excessive B cell survival. Now, one of the very important cytokine, which is an important growth factor for plasma cell leading to the proliferation, is interleukin 6. And this is correlating with an active disease and pointing towards a poor prognosis. Okay. Now, very important thing is that in plasma cell myeloma, as I told you, there is a bony destruction leading to an excessive release of calcium from the bone. Now, which is the factor which is responsible for this? One important cytokine, that is your MIP-1 alpha, also called as CCL3. It is a chemokine which is augmenting osteoclast activity, which is causing excessive destruction, leading to excessive release of calcium. Okay. Now, there are other things like, there are certain modulators of WNT pathway, which are also potent inhibitors of osteoblast activity, leading to decreased bone deposition. So the net effect that we are seeing, that there's an increased osteoclastic activity and there's a decreased osteoblastic activity, ultimately leading to bone destruction. Okay. Bone resorption, in fact, leading to an increased calcium release into the circulation. Okay. Now we are going to see some of the important features. Now, multiple myeloma. Now, before I go into the features of this multiple myeloma, let me show you how multiple myeloma is basically presenting. So, multiple myeloma basically involves destruction of the bone, and most commonly it is causing destruction of the vertebrae. Now, you can see they present as a very soft gelatinous mass. Okay, they present as a soft gelatinous mass, and you can see that there is a bone resorption. These are spaces which do not contain any bone. Why it has happened? Because of excessive amount of osteoclast activity and decreased amount of osteoblastic activity. So grossly, plasma cell myeloma is presenting basically as a destructive plasma cell tumor involving the axial skeleton. So the most commonly affected site in decreasing order is the vertebral column, followed by the ribs, skull, then pelvis, femur, clavicle, and scapula. Now, basically, the lesion is starting in the medullary cavity inside. For example, if I draw this bone over here, okay, so this is the medullary cavity, and over here, from here, the lesion is starting and then it is going outwards like this. Okay, and ultimately, when this entire bone is gone, then ultimately what will happen? There will be a fracture, and this fracture is called as a pathological fracture. So the lesion starts in the medullary cavity. It is going to erode the cancellous bone and it is going to enter the bony cortex towards the outer region. And ultimately it was called pathological fracture. So the most common site, as I told you, is the vertebral column. So in the X-ray, if you can see, you will see that there are punched out defects. Okay, there are punched out defects, and grossly, as I told you, you are going to see soft gelatinous red tumor masses. So as we can see over here, you can appreciate soft gelatinous masses and you can see punched out defects. Now let me show you the same over here. Now this is the skull. Can you appreciate the punched out defects? Yes, everyone. Can you appreciate the punched out defects over here in the skull? So
Yes, sir.
these punched out defects, they are showing bony resorption that is taking place, most commonly seen, most obvious in the skull bone, in the calvaria that we see. Okay. So if you do the bone marrow aspiration study, what you are going to see, you are going to see a lot of plasma cells. You are going to see the immature form, that is the plasmablast. Okay. You are also going to see certain bizarre multinucleated plasma cells also. I'm going to show you. I'm going to show you how they look like, and I'm going to discuss the points in detail. Now, can everyone appreciate? Okay. So can everyone see this? This is looking like a normal plasma cell. Okay. Can you see that all of the plasma cell, they are having a perinuclear clearing, which we call it as, what do we call it as? We call it as perinuclear HOF
Hello. Oh,
or halo or halo. Now, can anyone tell me what is the cause of this perinuclear HOF? Because of accumulation of Golgi apparatus around the nucleus. This is the cause of the perinuclear HOF, and this is normally seen in a plasma cell. Now, what we can also appreciate that there are certain multinucleated forms. Yes or no? There are certain multinucleated forms. Everyone will appreciate this. Yes, so this is the bone marrow. And over here, clearly from this picture, we can also say that the percentage of plasma cell is more than 10% over here. Yes or no? So this was the first criteria for the diagnosis. So this was the first criteria for the diagnosis of plasma cell myeloma, as we can appreciate. Yes or no? Now we can see that there are certain multinucleated bizarre forms. Now, can anyone tell me what is this? What is this that we appreciate over here?
nucleus.
Pardon, I couldn't hear. What does the plasma cell do normally? What is the function of plasma cell? It is to secrete increased amount of immunoglobulins or antibodies. Now, these are tumor cells that is going to secrete excessive amount of immunoglobulins. Yes or no? So over here, if you can appreciate, this is one cytoplasmic inclusion which is containing excessive amount of immunoglobulin. Especially this is one endoplasmic reticulum containing excessive immunoglobulin secretion. And what is this called as? Yes, can anyone tell me? It is called as Russell bodies, which we have already studied. Where we have studied in general pathology, we have studied about Russell bodies. This is what is the nature of this? This is one kind of a protein. This is one kind of protein, if you will appreciate. Now, sometimes what happens that this entire cell is containing multiple such grape-like vesicles. Okay. For example, how we can see and appreciate over here. And this is called as a MOT, M-O-T-T, MOT cell. Okay, when they contain multiple such Russell bodies or cytoplasmic inclusion bodies, we call it as a MOT cell. Okay, MOT cell. Now, as I already told you, cytoplasmic inclusion bodies, they are called as Russell bodies, as I've already explained to you all. Now, if these inclusions, they are present, okay, inside the nucleus, intranuclear accumulation of these antibodies, they are called as Dusher body. Okay, both of them are important MCQ. These are called as Dusher bodies. Okay, clear to everyone? Just wait one second. Okay, these are called as Dusher bodies. Okay. Now, sometimes these plasma cells are going to show a very fiery cytoplasm. Okay, these will show a very fiery cytoplasm. Okay, what is this plasma cell with fiery cytoplasm called as? These are called as flame cells. These are called as flame cells. And very importantly, because of secretion of immunoglobulins into the circulation, okay, these immunoglobulins, they cause the RBCs to stack over each other like this. Okay, and this is called as Roulier formation, which is characteristic but not specific for plasma cell myeloma. So this characteristic Roulier formation is seen in multiple myeloma, but it is not a very specific feature. It can be seen in other conditions like lupus erythematosus. It can be seen. Okay, so I'm just going to say whatever points I have told you. So basically, in plasma cell myeloma, you will see a lot of intracellular accumulation that is just showing, accumulation of immunoglobulins. Okay, we see presence of flame cells. As I told you, we are going to see the presence of mott cells. Then we are going to see what we have already seen, what is a Russell body, which is cytoplasmic inclusion, and intranuclear inclusion is called as Dusher body. Also, I told you, because the level of M protein is rising in the blood, the antibodies are rising, so they cause the RBCs to stick to each other, and this is called as Ruli formation. Okay, it is characteristic, but it is not a specific. It is not a specific for multiple myeloma. It can be seen in lupus erythematosus, as well as it can be seen in early HIV infection. Okay, now remember one thing, rarely the plasma cell myeloma or neoplasm might enter the peripheral blood, and this might give rise to what is called as a plasma cell leukemia. Okay, plasma cell leukemia. Now, can you remember which molecular alteration was associated with plasma cell leukemia? It was MYC, that I have already explained to you all. Okay, now very important thing is that the kidney damage, okay, in case of multiple myeloma is because of the secretion of Benz-Jones protein. And what are these Benz-Jones protein? Yes, these are the free light chains, which might be either of lambda or kappa variety. Okay, so I've already shown you these diagrams. Okay, now we are going to see the immunophenotype. So which markers are positive for plasma cells? So plasma cell tumors, they are positive for CD138. Not only CD138, they are positive for CD38 as well as CD138 and also CD56. Okay, some new marker is also there, that is called as syndicant. But most importantly, if one you have to choose a CD138. So clinically, what is the effect? As I told you, clinically, the effect of multiple myeloma is because of involvement of the bone. So patient might come to you with pathological fractures, yes or no? And they are going to show chronic pain. And because the cause of this pathological fracture is resorption of the bone, so there will be hypercalcemia. And what did I tell you? How much it should be? More than 11. The value should be more than 11. Okay, and because of this hypercalcemia, there are neurological manifestations in the patient. Now, very important that although you have an excessive amount of immunoglobulins, but these immunoglobulins are not properly performing their function. As a result, such patients have increased recurrent bacterial infections. And very importantly, one important cause of death is also renal insufficiency or failure, next only to infections. So infections are the most common cause of death, and second important cause of death is renal insufficiency, which occurs because of Benz-Jones proteinuria. Okay, now the pathogenesis, as I am going to tell you, of renal failure, as I told you, is Benz-Jones proteinuria, as I have already explained to everyone. Okay, now some cases of multiple myeloma might they have amyloidosis because of formation of AL type of amyloid. Okay, and that case also, this amyloid is going to deposit in the kidney and cause kidney dysfunction. Okay, now, in 99% of the patients of multiple myeloma, there will be an increased amount of immunoglobulin in the blood. And what do you call this immunoglobulin in the blood? This is called as the M protein. Okay, this is elevated in the blood. Or inside of urine, you are going to see some light chain that is called as Benz-Jones protein. Okay, so how can we appreciate them? We can see, we can do a serum electrophoresis, and further characterization is done by immunofixation. Okay, so let me just show you this particular diagram. So this is the normal electrophoresis where there is a spread of proteins. Okay, so there's a gamma protein, A protein, M protein, and then you have kappa lambda chains like this. Then if you want to spread out, you have to carry out immunofixation. So normally you can see the gamma, you can see the A, and you can see the M. IgM, IgE, IgG, and the light chains you can see they are equally distributed. Okay, this is the normal spread. But in case of plasma cell myeloma, you can see, compare over here, there is a very dark band. We call it as the M band. Okay, we call it as the M band. If we are carrying out immunofixation and we are going to spread out the components, we are over here, for example, we see there is one class, that is the IgG class of immunoglobulins are characteristically raised. And as I told you, the light chains are also raised. And if you see, out of them, only one type, the kappa variety, is increased. So over here, the kappa variety is showing an increased band. Okay, so this is how we appreciate, and this is how the characteristic electrophoretic pattern can be seen in multiple myeloma. Okay. Now, most multiple myelomas, you will see the M protein levels, okay, in the serum is more than equal to 3 grams per deciliter. Okay. Or the Benzone protein, that is the free light chain, okay, in the urine is more than 6 milligram per deciliter. It is milligram. And over here, this is gram. Okay. So there's a difference. Okay. Now, which is the most common type of immunoglobulin or M protein that we see? Most commonly in 55% patient, we see IgG variety. As we can see over here, the IgG variety is this. So this type of multiple myeloma is containing IgG type of antibodies. This is followed by IgA variety that is seen in 25% patients. Okay. And very rarely do multiple myeloma, shows IgM, D or E class. Okay. Now, very important, excessive production of an aggregation of the M protein, usually of the IgA or IgG3 type, leads to symptoms of hyperviscosity in 7% of the patients, which I've already spoken about. And both the free light chains and serum M protein are observed together in 60 to 70% of the patients. This free light chains they're talking about in urine, that is Benzone protein. Okay. And this is the serum M protein, which is seen in 60 to 70% of the patients. Okay. Now what is very important to understand over here, that in about 20% of the patients, if you see, they will only show free light chains. Okay. And around 1% of the myelomas are non-secretory. So as I told you, they have all the signs symptoms of diagnosis, but they are not having any secretion. Okay. So this is called as the non-secretory variety, which I have already mentioned in the classification. Now, very important, the clinico-pathological diagnosis, as I told you, that either you should have 10% plasma cells in the bone marrow. Along with that, the myeloma defining event, that is the CRAB criteria, should be present, which I've already told. The full form of CRAB is hypercalcemia more than 11, renal dysfunction more than 2 should be a creatinine, anemia, hemoglobin should be less than 10, and at least one lytic lesion should be present radiologically. Okay, so you have to do a BMA examination and you have to carry out these tests so as to make a diagnosis of multiple cell myeloma. Okay. Multiple myeloma. Now the median survival of multiple myeloma is just 4 to 7 years, and patients of multiple myeloma, they are usually presenting with multiple bony lesions. Okay. As I told you, and patients who are, in whom you can see multiple bony lesions, they survive rarely more than 6 to 12 months. Whereas patients who are having smoldering myeloma, that is, they do not have any CRAB criteria. No CRAB criteria is present in smoldering myeloma, but they will show M protein. Such patients, they can live for many years. And I already told you, there is a certain prognostication along with the molecular lesion. Now, for example, patients with cyclin D1 mutations are associated with a good outcome, whereas deletions of 13q, 17p, and translocation 414, they are associated with a aggressive course. Okay. So one very important prognostication, as I told you, as I was speaking about the prognostication, this is taken from the latest WHO, and in the latest WHO, they have given this very old but very important prognostication, that is the international staging system of the plasma cell myeloma. So according to the serum beta 2 microglobulin as well as serum albumin levels, we basically grade, okay, for how many months the median survival can be predicted. Okay, so remember the stage 1, where the serum beta 2 microglobulin is less than 3.5 gram per deciliter and the albumin level is more than equal to 3.5 gram per deciliter, the median survival is 62 months or around 5 years. The stage 3, where the serum beta 2 microglobulin is more than equal to 5.5 gram per deciliter, here the median survival is approximately just 29 months. And those who are not falling in either of these categories, they come in stage 2, where the median survival is 44. So just remember very importantly, which are the parameters which are used in international staging system, that is the beta 2m and the albumin level. And this was asked actually in AIMS, and this is a very old repetitive question that is asked in AIMS. Now, very important stratification is the Mayo stratification, which is based on the type of molecular alteration which is present. Okay, so for example, there is a group which is standard risk, there's a group with intermediate risk, there's a group with a high risk. So these are the mutations. I'm not going to the details. You can go through these mutations which are associated with a good and bad prognosis, but certain ones which are important, I'm going to tell you. Translocation 1114, hyperdiploidy. Okay, these are having a standard risk with 8 to 10 years survival. Translocation 414, hypodiploid, they have a 4 to 5 year survival rate, and deletion 17 or any translocation involving the 14, that is 14, 16 and 20, okay, they are associated with a very bad prognosis, and they have just a 3-year survival rate. Okay, so this is all about multiple myeloma. I hope you all have understood about multiple myeloma. Any doubts you have with regards to multiple myeloma? Yes, anyone?